as well? No. And it can inhibit contractions, right? Because of the stress hormones that are being activated by the endorphin, right? Now, this is also where our epidurals can be helpful, because if there's so much stress, tension, fear, tension, pain, right, and their endorphins can't keep up, they're not coping, what do? You calm the body, right? And all of a sudden, what do we see? The 1 centimeter patient that's been 1 centimeter for forever, all of a sudden is complete. Okay, so there's some correlation between all of the hormones and all of that. Okay, now if they have too low of levels, it might not give enough coping, right? And so there are ways to activate endorphins in order to help them cope. Therefore, the whole hormonal cocktail works perfectly together. And now, in order to activate endorphin, fun fact, you actually need pain, right? And so that's where hacking, or like our spiky balls, are one easy way. There's various reasons. I talk about that in physiologic coping too. But when we have a little bit of pain, the body's like, oh, let me give a little endorphin coping, right? It's not, I'm not breaking the skin, but spiky, right? Hacks on the body to help them cope. So what can we do to help release endorphins? Really, anything we do for oxytocin helps with all of the hormones. So that's sort of baseline. On top of that, education, lowering their stress, and epidural may help with some endorphins, keeping mom and baby together, all of our oxytocin interventions, because if it's too high, it goes with adrenaline, okay? Those counteract our labor hormones. All right? So we're gonna do a little breakout activity. And I know some of you are in groups in the room. If you're in a group together of at least 3. So if you're 2, you can join the other groups on a call. But if you are 3 or more, you're going to turn and you're going to break off on your own, okay? You will still be assigned to a breakout room. And so if you're in a group, you can kind of be like, hi, bye, and just sort of do your own thing. And then the people that are in the room can go forward and do their breakout activity together, okay? And so Sophia's actually going to drop the hormone case studies into the chat. But if you go to your workbook, I think it's page 13. Yep. So on page 13, you have your hormone case studies. And if you don't have them, once again, it's coming in the chat. So you can open those up. And we all know that, like we know this from COVID, right? You get in a Zoom room with a bunch of strangers and you're kind of all staring at each other awkwardly and like, we good? Who's going to talk? I'm not going to talk. Who's going to talk? Just make a decision. I'm just going to jump in. I'm just going to start. Hey, I'm so-and-so. And what you're going to do when you get to your room is you're going to introduce yourself and go around, just popcorn in and say like, I'm so-and-so, where you're from, how long you've been a nurse, and 1 word to describe you as a nurse. You kind of do a little intro, get to know where each other are from. That part to me is like the biggest gift of doing this job, because we get to meet people from all over the world. We realize we're really not alone. Okay, and then somebody's just going to say, I can lead, okay? And you are going to read the case study, go to the case study applicable to your group number. And so Sophia's also going to drop in the chat, based on your breakout room number, what case study to do. Honestly, you can just choose a number. Choose a fun number that you love and do that case study, right? If you get done with one, you can go on to the next one if we still have time. But what you'll do is you'll read the case study to the room, and then after reading your scenario, you're going to discuss how the patient's hormones may be disrupted, and then also find potential practical nursing interventions to facilitate healthy release of maternal hormones. Does that make sense? So one of the things you'll hear me say when we come back from break, because we're going to come back, put it all together, and then we're going to go on a break. So if you're holding out, we're getting there, right? But when we come back, one of my phrases is don't write their story. And what that means is like, we're not deciding what's happening with them. With that being said, in this scenario, we are. Okay, so I want you to put yourself in their shoes and imagine how they could be feeling. Put yourself in the patient's shoes and then the nurse's shoes and say, how can we support this patient so that their hormones are optimized? All right? And then once you get done with your scenario, I want you to discuss what are some practical changes you can make to your practice to help support healthy hormone release. What's maybe just a little tweak? And again, I'm not asking you to totally change your practice. These are just like a different approach, a different mindset. I'm going to try this. I'm going to get on their level. I'm going to look in their eye. I'm going to call them by name. I'm going to learn the partner's name and the doula's name and include everyone in the plan of care so that they feel like we're all a team together. Okay? So Can you unflip the screen so I can see them? All right, so what's gonna happen is there's gonna be a screen that comes up on your page, and it's gonna say enter breakout rooms or something. She's gonna open up the breakout rooms. You'll say go. And if you're having an issue getting to your breakout room, just chat us and we can manually assign you to your breakout room. But you'll be automatically assigned. There'll be 16 different breakout rooms, and you can choose a case study. If you need a guide, it's in your chat. And then when you break out, talk to each other, go through the case study, talk about the changes in your practice. You're gonna have 20 minutes, okay? So 20 minutes to discuss. We'll come back, wrap it all up, take a break, and then keep it pushing. Okay, now if you're in a big group, just turn to each other and put yourselves into groups of about 4, depending on like the odds and evens in your group, about 4 people together. Okay? We'll see you so soon. Have so much fun with each other. You can come on back, make your way. For those of you that are back, feel free to drop in the chat some of your takeaways. What were some of the things that stood out? What were some of the I never thought of that, or I'm gonna do that now. How did the discussion go? And as you do that, I think everyone's back, right? No one's left. All right. As you go, I'm going to just kind of wrap us up, and then we will go on break. But as we're on break, you can feel free to keep telling each other what you learned so that we can kind of all collectively learn from one another, because the collective wisdom in this room could really make a difference, don't you think? So what do we know so far? We know that birth is complex, and we have barely even gotten started. We're literally just talking about 5 hormones of the many hormones that all work together to help birth the baby. And so we know it's complex. We're going to keep even building more on that. We also know that it is sensitive to outside influences. Okay? And so I think that is one of those key things. Write that down. Birth is sensitive to outside influences. How does it get influenced from the outside? Who's in the outside? Us. And so birth is sensitive to us. And by birth, I not only mean the birthing experience, but I mean the work of birth working. We know that some of our key words are private, safe, and unobserved. Because if we go back to those oxytocin interventions, if we can keep the patient private, safe, and unobserved, we're not disturbing birth. But if we don't, we are disturbing birth. Okay? You can have an impact on their labor hormones. But what do? We are in an industry of observation and monitoring with a habit of disturbance. Think about it that way. I'm like, oh, okay. And by knowing that, how would you shift your practice so that you're not staring at their vagina during a vaginal exam or a cervical check, right? Or while they're pushing, right? Instead, we just kind of back off and we're not observing quite as much. We provide some more privacy. We pull the curtain, latch the door, right? And while we're monitoring, it's about our approach. I'm not saying don't monitor your patients. I'm actually saying monitor your patients and assess them constantly. Right? But we're in an industry that is sort of set up to disrupt birth, right? It's not the same as a home birth. It's not even the same as a birth center birth. And so how do we adjust our environment to disturb birth less? Now, we also know that we use techniques that are painful, that cross body and social boundaries, and are performed by a stranger. Okay? And while, again, that's not necessarily going to change, but could our approach change? Right? That's why that rapport building and that psyche support and that like connection and the respect and our approach in the room makes such a difference. Because we're already setting ourselves, our profession, the hospital in general, sets the patient up to be disrupted and potentially affect birth. And so it takes a little bit of a shift in our approach. We also know that there is culturally a deep distrust of the birthing person's body. Now, what do we hear? What does this look like in the public? All those horror stories. And what does it sound like for us when they get to the bedside? Well, what do you want for your birth? What's your dream? What are your goals? Well, I really want to give birth vaginally if I can. I really want to breastfeed if I can. I'd really like to go without an epidural if I can. What's underlying that? If we think about the words being used, if I can, and you get to be that person that says, if you can, we're doing it. If that's your goal, my goal is to help you achieve that. If that's what you want. No ifs, ands, or buts. You're gonna do it, right? And all of a sudden they're like, okay, they believe in me, right? You might be the first person that tells them that their body can do it, that tells them that they can do it in a moment that when they do, no matter what that looks like, with or without an epidural, doesn't matter. When they do, will transform them for the rest of their life. This is a story they will tell forever. You get to be the one to tell them otherwise and encourage them. We know that when you limit disturbance, you optimize their hormones. And so we have our tool. Is there anything I can do to help you feel more safe and comfortable? And see where that takes you in your exploration of helping optimize their hormones. Deal? Are we good so far? Making sense? We got our foundation laid because when we come back from this break, we are going to start talking about the different body systems. We're going to go one at a time of how they all work to help support with some nursing interventions to optimize them to help get the baby out vaginally. Sound good? Drop your reflections in the chat. You can read each other's while we're on break. Go for 10 minutes. We will be back at 9:57. And I mean that for 10 minutes. Like, I know it's only 3 minutes, but those 3 minutes, we got so much to go over today, and I want to make sure we have all the time to be able to do so. All right? Enjoy your break, stretch your legs, get a snack, some caffeine, and I will see you so soon. You can start heading on back. We'll get started in about a minute. If you are back, Sophia has dropped some links mentioned already. The Pause at the Door podcast episode I know I mentioned. If there's other links you want, let us know. We got lots of links for random things. I love all your reflections. Lots of education on your reflections. There was, Doreen had said, what does unobserved mean? We have to observe and evaluate. I'm not sure if that was a question, rhetorical or not. I will say that unobserved is our approach, right? Rather than observing and staring and whatever, it's our approach is, would it be okay if I palpate your contractions? Sure. And they're in the zone and we hear, rather than standing over, get on their level, lower the lights. Don't make them feel like they're quite so much on display. You're still observing, obviously, right? But we want to just shift our approach so that we can think about ways that they're feeling less observed in that way. Okay? All right, we ready to go? We alive? Okay, we're going to hit the ground running. Not that we haven't already, we have, but we're about to move. All right, how many of you have heard of the 5 Ps of labor? Okay, this comes up especially now, like in the last few years. I hear it in like other education stuff where people reference back to the 5 Ps of labor. This originally comes from Penny Simkin. Rest in peace. If you haven't read the Labor Progress Handbook, please get that book. I'll have Sophia drop the link in the chat for you. That is one of our essential toolkits that also, like a lot of the stuff you learn here and in physiologic coping in our coping with labor class is in that book, okay? So Penny Simkin came up with the 5 Ps of labor, and the idea is that these are the 5 things that need to align in order to have a vaginal birth. Okay, we know this, right? The passenger needs to tolerate labor, the baby. The position of the baby matters. Obviously, if they're breech, can they deliver vaginally? Maybe, but most of the time in hospitals with our current state, not so much, right? Now, on top of that, I will add, in the picture you see breech, but also, that also means vertex in various malpositions, the position of the head, whether it's OP, OA, asynclitic, flex, not, we're going to talk about all of that, okay? The passageway matters, aka the pelvis. Okay, I love talking about my pelvis. We're going to talk all about the pelvis today. So the passageway, meaning the bony structure, matters. The power, meaning the strength / the contractions, matter and how it changes the cervix. And then the psyche. I love that this is included. We're going to break down each one of these, but I'm actually going to add some to this list because especially when you think about the anatomy of the pelvic area, we know this, but I want you to think about it. Is it just bone? Obviously not. Like there's a lot more going on in mine, right? And so what else is in there? It's not just the way that the pelvis moves, the way the baby navigates the bony structures. There's a few other things. And so I'm going to add to this and show you all the things, okay? And so we are going to add on to the 5 Ps and also break down the pelvic floor. How many of you have had some formal training on the pelvic floor before? Right? I see this in every single class, and I'm like, it's like all of our tearing, perineal massage, like the pelvic floor is extremely important. So you're going to get it today. Kind of wet your whistle in that front, okay? We already talked about the hormones, and I separated those from the psyche. They are separate. Now, mind you, they're closely related. I'll have to whip around my pelvis. They're closely related, but the hormones interact with the psyche, and the psyche interact with the hormones / the rest of the body, okay? So we're going to split them up with the hormones. There's also ligaments in there, and there's fascia, which we're going to break down, and we're going to talk about what we can do to help assess and then adjust based on that. Now, is it cyclical? No, it's a hot mess in there, right? They're all interacting with each other, and if one or more are disrupted, then it can lead to a dystocia. They all sort of need to work. Now, the reality is, for the most part, they do. Right? All of these stuff, there's so many adaptations, there's so many adjustments that can happen along the way to help get the baby out, right? And we see it day in and day out that this is working. But as a framework for our assessment as nurses, I find it helpful to think through the different systems in the body when we're saying labor is slowing, something's not right, I need to adjust, or we're going to lead to a C-section. I got that phone call. I hear this at the nurse's station about my patient. Hold the phone. Let me go through each system and assess it, know normal from abnormal, and also possibly apply some nursing interventions to help optimize that area of the body, knowing that they all work together. Sound cool? Okay, let's do it. First, we have to recognize, you've heard it before, labor works. And it takes time. If we look at the Zhang study, or like when we're looking at labor curves, and there's Friedman's, there's Zhang, there's lots of other ones, okay? What we've found over time, how many of you remember the 6 is the new 4 movement? You've been around for a while. I remember for me, that was like right when I was coming off as a new nurse, and they gave me this massive, ugly button that they wanted us to wear every shift. And so I remember like it getting in the way and having to wipe it off. 6 is the new 4. And the point is that prior to that, we thought that active labor was 4 centimeters. And so once you hit active labor, we know it kind of takes off, that we expect regular cervical change. Prior to that, with early labor, we don't really care how long it takes unless there's a risk, right? It takes time. And so they actually pushed that out to 6 centimeters, and then the standard changed, where now 6 centimeters is considered active labor. Now, is that a perfect science? No, because we also know that people come in at 4 centimeters and then they quickly dilate, right? And so labor and birth is a very weird specialty in medicine as scientists, okay? I'm gonna start referring to myself that way. All right, that it's kind of a weird specialty, that there's so much art, right? That it's not a standard way every single time, and that's what we love about our jobs. It's always different. But at the core, we have to check our own bias at the door and say, do I actually believe labor works? So go back to that patient that I talked about, where like the provider was the one like, do all the natural stuff. And I'm like, yeah, right. I have bias that I am constantly checking. And then I reinforce with education, I reinforce with my lived experience, and I reinforce with physiology, right? And so let's push back on that. When we're finding ourselves fighting, but what if we started with, I'm going to believe that it works? And I also know it takes time, and so we want to fight for that time. We want to advocate for that time, not fight, advocate. Okay, and we know if it's not working, we have to ask why, because we have tools, all right? So let's start with the psyche. We know that the psyche is often forgotten. We know that it matters to us, especially as nurses. We're the ones at the bedside, hearing their stories and crying with them and, and helping them cope and all of that. But it is often forgotten, and we have to think about it as a component of the physiology of birth. Okay? Now, with the psyche, I have to talk about coping, because coping is a huge component of how we help the psyche be in a safe place. If we heard of the combination of coping versus suffering, this is also a Penny Simkin, and I love this framework because Also, labor and birth is weird when it comes to pain because you have patients in any other area of the hospital. Our job is to treat pain. It's the 6th, 7th vital sign, whatever, right? And so our job is to treat pain, but in labor and birth, they're like, oh, I'm in so much more pain. And what do we say? Yes, we love it. Woohoo, good job. You're like, thanks, right? Now, there is a difference, and we've seen it, between coping with pain. They have pain. It's not going to have a lasting impact on their life. It's like it was painful, right? You've had headaches that you don't remember. It's probably not suffering, versus suffering, which is deeper. It's more emotional. It's more impactful, risk for trauma. It's the patient who grabbed my scrubs and said, my soul hurts. And I was like, ooh, that sounds a lot like suffering. Not, I have painful contractions and I'm okay, I'm coping, right? When in doubt, ask them, right? And if there's signs that you're uncomfortable with the way that they're coping, regulate yourself. Because how people cope might feel really uncomfortable for you, and you might be shaking as you get your gloves on to like check them because you think that baby's coming, right? Instead, take a deep breath, okay? Let them cope, let them retreat. When they're outside of their neocortex, they act real weird. And that's great. That's a sign, and you want to encourage that by the look on your face, even though you're freaking out inside, okay? We also know that everybody is bringing their entire life history into that room. And we're not entitled to that story, right? We also have never walked in their shoes, and we never will. But when we pause at the door and we commit to giving ourselves to that patient, no matter how different they are from you, no matter how much you relate to them or not, no matter how much they look like you or not, that you check yourself at the door and you go, I don't need to know why, but I'm going to give them the benefit of the doubt. And this is where don't write your story comes in. Okay? I believe, and I am sticking to it, the more I live, the more I experience life, the more diverse experiences that I have, that this is one of our main problems in society today, outside of birth, and it very much applies to birth. But what do? We decide who each other are. And we do it at the nurse's station. We do it with our providers. We do it with our coworkers. We do it with our patients. We do it with our family members, right? And really the reality is that our bodies, our brains are meaning-making things, right? We have to, in order to survive, we have to make meaning of what's going on around us. Am I safe? Am I not? Et cetera, et cetera. But as we're making meaning, instead of asking and getting curious and calming our own bodies and not taking so much personally, we decide who each other are, and we do it to our patients. Myself included, I'm guilty of it as well, right? And what that means is don't write their story, is don't decide who they are in the most vulnerable day of their life. And what do? We go to the nurse's station. Oh, look at their dynamic with their partner. I never want their partner. They got issues, right? Or God, she's so anxious. My word. She keeps moving, and like I just adjusted the monitor. And I just told her to stop moving, and now I'm back. Okay? Exaggerating to prove a point. I'm sure none of you have ever felt this way. Okay? But I have, for sure. Right? And it's easy. We decide who each other are, and we don't give people the benefit of the doubt. At bare minimum, when you're in labor, when you're feeling dependent and vulnerable and scared, where there is potential harm to you and something you love, don't you want someone not deciding who you are and giving you the benefit of the doubt and just showing up being like, I'm here. I'm not going to pass judgment. You do you, boo. We're here for you. I'm here for it. However it comes out, let's do it together. Doesn't that feel so much better? Doesn't that feel better when your coworkers also do that? Okay. And so this piece for me is one of my life mottos. I check myself constantly. I'm like, don't write their story. Don't write their story. Take it into your regular life. But don't write the patient's story. We don't need to know why. But we're going to give them the benefit of the doubt that we're sure that they have a good reason for however they're acting. Now, when we're trying to coax the psyche, right? It's like a cat in a tree. Imagine. What happens if a cat's up in a tree freaking out, right? You come up and you grab the cat and you pull him off. What do? They go, woo! And they're holding on. You're trying to pry the claws off. And you're like, oh my gosh. And you cannot get them off that tree. How do you get a cat to come into your arms when they're safe? What do? Here, kitty, kitty. You gotta come my way. You gotta let go. You gotta calm. They gotta trust you. And all of a sudden they start to come. It's the same way. One with the cervix, kind of. And two with our patients. And so we can't force them to trust us. We can't force them to do something they don't want to do. We can't force them to cope. Instead, we have to set the environment so that it tells their body by fact and their own interpretation is as clear as possible. Again, they have their own lens, so we're not responsible for their lens and what they've been through, but we are responsible for setting an environment where they feel safe, okay? And if they can't with you, then great, try somebody else. Maybe they need someone different. Maybe it's not a good match, that's fine, okay? We want to coach it in, coax the patient to, not manipulatively, right? We want to provide a safe environment so they can come to us, okay? Now, the other thing is, we know this, when they're so tight in their jaw, their cervix is also going to be tight. I want you to do a Kegel and squeeze those vagina muscles, that pelvic floor, and really give it a nice little squeeze, okay? Do a tight, tight, tight Kegel, and now clench your jaw really tight and make the whole thing super rigid. Now release your jaw. How many of you also let go of your Kegel? Okay? They're naturally connected. And so if you see jaw here, there's something going on. They're holding on to some sort of tension. Okay? It's one quick tip amongst many. Okay? Now, when we look at trauma, you can read some of this, but I want to point out that one's perception of the event is what defines the event as traumatic or not classification from the physician. This is really important. And so when we're trying to set the brain up to interpret its environment in a way that it knows that it got what it needed for survival, that's sort of baseline for helping avoid trauma, right? Somebody could have the exact same experience as you. You could have an experience where you walk away and you go to that pack and you go, wow, that was really traumatic, wasn't it? Be careful. Because very quickly you introduce to that patient what? When they're feeling so grateful, so happy, so good about the outcome, right? And so we want to leave it open for their own interpretation. And they could have a perfectly normal, low risk, non-intervention, follow the birth plan to a T, vaginal birth, and be traumatized on the other end. And so when we look at what sets someone up for trauma or not, the biggest risk factor for birth is low levels of support, them feeling alone, okay? And really it's subjective distress. Subjective, meaning they felt distressed and they didn't have the capability to get out of it, okay? And so low levels of support, that's from us, right? That we come alongside and say, I am right here with you. How many of you have done this? You have, I know it, right? That in the emergency, you walk in and you're like, how can I help? And everyone's kind of on their own thing and wah-pah for the whole situation. And you walk over to that patient, you look them in the eye and you say, we are doing everything possible. We are not alone. I'm going to stay right here with you. That is a nursing intervention and protective against trauma, which leads to potentially helping prevent long-term effects of trauma, like PTSD. It's highly comorbid with postpartum depression, et cetera, okay? And so we start here because so often everyone's very excited to get to the positions, which we will, okay? But if you take away one thing from this class, it is pay attention and own how you show up at the bedside. For the physiology of birth, of course, for better outcomes, of course, but also for this, because this also matters as well. Is there anything you could do and that I can do to help you feel more safe and comfortable? Or is there anything that is or you could anticipate causing you anxiety today? Or how can I help? I'm noticing this. How can I help? Right? Now, some quick, potentially easy nursing interventions are breathing exercises for the psyche, okay? When you elongate the exhale, it activates the parasympathetic nervous system. Hack for the brain. We have a whole grounding techniques class. It's only I think it's like $20. Might even be less. Okay? That teaches these kind of down-regulating techniques also for yourself, because we need them as well. Guided relaxation comes in. This addresses the psyche, right? We've heard of like the golden boat visualization. I've heard of this. It's like with my childbirth education training. Like imagine you're floating on the water, right? You hear people with their hypnobirthing scripts or visualizations or meditations. All of that helps activate the parasympathetic nervous system, help the brain. But what if they can't relax? And so I'm going to give you a new tool related to the psyche, okay, to set us up. And this is called paradoxical relaxation from David Wise, who's a PT. And the goal is to reduce nervous system arousal, which, by the way, decreases adrenaline, helps your labor hormones to be optimized, decreases activation of the sympathetic nervous system, all right? And so the first thing you need to do is identify obstacles to relaxation. So if the lights are on, if there's beeping noises, if mom's in the room of the patient and you can tell there's a dynamic and the patient's like, I really need some help, then, we're going to set up the room and we're going to, ask everyone to step out and give them a moment. maybe not. Okay. And so instead of relax your body, breathe with me, which you can do, but oftentimes we find those patients who just can't relax and they're just a bundle of tension. Okay. And so what you do instead is we want to deliberately deprive the nervous system of the stimuli which causes the arousal. And so you're going to have them focus on one area of the body. And I always use my hand because it's so easy. You could use a foot as well if you see their toes curling up, or a brow. Okay. I'm going to use hand for an example, but it could be brow, foot, anywhere else, shoulders. Okay. And so between contractions, this is not during contraction, let them go, get through it. Okay. Between contractions, have them relax an area of their body. Okay, start with the hand. I want you to relax your body. Let it lay heavy. Feel that relaxation. And then when the contraction comes, your only goal is to keep your hand relaxed. I don't care if you tense up anywhere else. I don't care if you yell and scream, but I want you to really focus on controlling that relaxation in your hand, because we're one body system. You try it. You cannot tense up the same way when you deliberately focus your energy. It's also a distraction technique, right? That they're focused. I'm relaxed, I'm relaxed, I'm relaxed. The rest of the body, including the tension in the pelvic floor, follows suit. Okay? So if you're seeing it everywhere, have them focus on one area of the body, that it's the furrowed brow. I see you doing this with your eyes. All right? During the next contraction, no matter what you do, I want you to focus on keeping your face relaxed. Okay, everywhere else we don't care, just your face. All of a sudden they're like, guess what? They're deliberately focused here instead of here, which we know physiologically helps with coping. It also helps with relaxation in the body, helps improve their experience. Cool? Psyche. Lots of other techniques, but that's what I'm going to give you today. All right. Moving on to the powers, which is our juicy contractions. We want a juicy, squishy orange of a contraction that gives all the yummy juices to help everything flow. I don't know why, but I think of a smushy orange or a ripe mango, right? When you think of birth. That might be very birthy of me, but it's okay. All right, now what do we want in the powers? We want strength and frequency. We can have super strong contractions that happen every 20 minutes. Will that birth a baby as quickly as ones every 3? Probably not. Flex and flow, but in general, no, right? So we need the combination of strength and frequency. How do we assess the power? Meaning the uterus. Our hands. Thank you, Doreen. Yes. Okay. Our hands are our biggest tool. And what are our hands most of the time doing? Instead of palpation, right? With consent. Would it be all right if I feel your contraction the next time you have one? Of course. Would it be all right if I do that regularly? Yeah. If you ever don't want me to touch you, just tell me. Okay. All of a sudden I got more control. And that is important for patient satisfaction as well. So I'm palpating those contractions. When you chart on that tracing every 30 minutes and you chart that they are mild, are you actually feeling contractions every 30 minutes to assess for mild? I'm sure you are. I'm sure. Okay. But let's make sure that we are every single time. Okay, and the more sensitive we become with our fingertips, the better we can actually know what's going on. Because palpation for contractions is one of the many ways that we palpate through the process. We've got to use what we got. We have these fingertips that can learn even more and get better and better at this. All right, so we got to palpate those contractions. Mild, medium, strong, right? Mild, medium, strong. Okay, learn that in nursing school maybe. Okay, the goal with contractions is to keep them coming. All right, and so we know that reflex, right? Oxytocin's released, causes contractions, more pressure on the cervix, more oxytocin, etc. And so the goal to keep contractions coming, ideally, is pressure on the cervix, okay? And sometimes an epidural can actually disrupt this cycle because the pressure sensation and the way the body interprets it is a little different, okay? So does labor slow with an epidural? We're gonna say not really, right? But physiologically, could it affect it? Yeah. Is that going to make a difference in how we care for our patients? If they want an epidural, they're getting an epidural for sure. because coping is also important with their experience. Now, how does the power happen? I think this is fascinating about the way the uterine muscles work. There's 3 layers in our mammalian uterus, if you have a uterus. All right, the outside layer has muscle fibers going from top to bottom. And so what is the action? To push down when it contracts, right? And obviously as the cervix goes, the fundus gets stronger to have more contraction, and actually thicker in the fundus. Okay, so that outside layer pushes down. That inside layer has muscle fibers that can go in any direction. This is adaptation to help the baby navigate the pelvis. So the baby's coming down a little wonk, that all of a sudden the body's like, ooh, let me squeeze you over here to align you and let me help you bring the baby down. Okay, that's the middle layer. And then the inner layer is a peristalsis layer, peristaltic layer, right? It has peristalsis in it. And so it goes vroom, vroom, like our digestive system to help move the baby down. Isn't that fascinating and so cool? So obviously we want a really well-functioning uterus, a very well, I was gonna say well-hydrated, I suppose a well-hydrated uterus, but also a well-oxygenated uterus, right? In order for it to work, because we need those adequate contractions in order to ideally have everything work. So if there's inadequate contractions, the first question is we have to assess, are they inadequate, right? If labor's slowing, stopping, we go, what's happening with the contractions? How do I know? I palpate. They're 9 centimeters. Their belly is pretty much smushy when they have a contraction. They don't feel strong to me. That's abnormal, okay? And there's no cervical change, potential for inadequate contraction. So what could be the cause? Immobility. The moment you start to shift the uterus, it reoxygenates and it helps to activate it to be more strong. It's where our position changes matter. That upright matters. That movement matters. If they've been in the same position for a while, flip them, move them around. That can help. Okay. Did they have a medication that may cause less contractions? They just got TERB. Of course, we're going to have inadequate contractions. Are we stressed about it? No, but it plays into our care, right? Because we know that they're not going to be adequate for a little bit. Okay. And so we got to get it back. Have we overhydrated them? This is one of my soapboxes. In L&D, we're not that great at paying attention to our eyes and nose. We have mostly healthy patients, right? We throw them a bolus here and there, give them 500, give them 500. Oh, Tracy needs 500, right? And all of a sudden, within a 24-hour course, they've gotten 6 liters if we're not careful, especially with those tracings. Okay, and so have they been overhydrated? We got to really be paying attention and asking them how much they're drinking. Paying attention to that, because we may not see it in L&D, but in postpartum, they go home, they get readmitted for pulmonary edema because we did a number. Okay, so we really got to be paying attention to our hydration. Okay, and obviously like underhydrated as well, right? That we want to make sure they are hydrated. Are there emotional factors getting in the way? And then what's the position of the baby? Because if the baby's not entering correctly, by correctly I mean ideally with pressure on the cervix, you're not going to get that reflex. So what do we do? Okay, some of our nursing interventions, nipple stim. I just read an article, which I didn't, it's in a pile of articles over there. And so basically the article said that it is not, like the whole hypothesis was that like nipple stim will help increase vaginal birth rates kind of in comparison to Pitocin. I was like, oh, okay. The answer was it did not. Like Pitocin was more effective in causing contractions than nipple stim, but nipple stim did. And it does, right? And physiologically, it does make sense. Now, is it going to cause them to go and appear like a Pitocin would 30 minutes later? They're starting to feel a little more, 30 minutes later, blah, blah, blah. No, but can it contribute to the full picture? Absolutely. Can it give control to the patient? Absolutely. Now, remember, the nipple stim that's most effective is one that they kind of like it. That they're like, little tickle, tickle, right? It's like foreplay. Foreplay also helps release oxytocin. Get them up. Walking in position changes can help shift the weight of the uterus, reoxygenate in new ways, help the baby shift, give the uterus some stimulation as well, right? We know when they walk, they're like the contractions start coming a little more. How effective they are, flex and flow. But if we're not having enough, we want to keep them coming. Acupressure, we're going to look at in just a second, getting them in some hydrotherapy, and then obviously assessing and addressing the position of the baby if it's not really hitting the cervix so much, okay? Get it engaged. So we're going to look at some acupressure, an acupressure point. You're actually going to watch a video in a second, and I want you to try this on yourself. This is a tool for your toolbox. Depending on the research that you look at, a lot of our Western research would say that it's a tool, there's limited data, it's potentially ineffective. But also, when we're looking at evidence-based care, what did we learn in the beginning? Potentially effective with the least harm, right? And in general, obviously, I'm going to say that you're talking to your providers. Even in that case, there was a provider that was like, yeah, do acupressure. Like, talk to them about it, especially if they're on PIT. We don't want to cause tachysystole, right? But to give a little boost and a little natural way to help support synchronous contractions, it's a tool for your toolbox. It also gives control, right? And if we're looking at the patient experience, right? In general, patients are typically very, very happy with acupressure and feeling like I did something to help. And also for partners, pull in the partners. You're not sitting there for every contraction pressing on the points. You help them find it, get them settled, pull in the doula, right? And then you get to do all your things and check on your other patient and all of that, okay? And so what we're going to learn in the next one is one acupressure point located on your ankle. So if you have an ankle, I hope you have an ankle. If you have an ankle, I would like you to access your ankle and actually try this for yourself. All right, now, if you are pregnant and less than 37 weeks, please find the spot and then don't hold it. But if you are not pregnant or over 37 weeks and you're ready to go, I can't imagine this is going to cause preterm labor, but of course I have to give you that precaution. Okay, and so when we go through this video and learn about this pressure point, San Yin Jiao, it is one tool for your toolbox to help support these synchronous contractions getting stronger and closer together. This is what I use with my patient, okay? And it's located on the inner part of your ankle. So if you want to kick off your shoe, cross your leg, access your skin, because you need to be on skin, I want you to find it and go along with the ride as we learn from Kate Levitt.
One of the main points that we use during labour is spleen 6, or San Yin Jiao, and this is a major oxytocin point. Spleen 6 is a major gynecological point in Chinese medicine. It's the point that you'll probably use the most, both before and during early labour, to help stimulate contractions. It's also effective if you've had an epidural because it's the oxytocin point. Oxytocin is the main hormone of labour, and it's what really stimulates those amazing contractions that will help you give birth to your baby. But remember, not to stimulate this point too strongly before 37 weeks because it's a labour promotion point. Lauren is just 37 weeks pregnant, so we can locate and find the point, but we don't want to stimulate too strongly. The way that you locate this point is on the inner ankle, placing one hand on the ankle bone. You can start with your little finger or your forefinger on the ankle bone, whichever hand has easier access. Remember, the measurement is based on mum's body size, so measure your hand against hers. If your hand is slightly smaller or slightly larger, adjust the hand width so it's the same size. So placing my hand on the inner ankle bone, my little finger is touching the bone, and spreading my fingers just slightly to adjust for mum's hand width. The point is located where the uppermost finger is resting and just slightly behind the bone towards the back of the leg. If you run your finger gently up behind the bone to about where you know the point is, you'll notice that the skin feels slightly softer or a little bit silky at where the point is. The point's different on different bodies, so this is a really good way to feel for it. The way that you stimulate this point is first locate it using your hand width, and the point will be at the topmost finger. Remember to roll to the back of the bone. You can use your forefinger or your thumb to locate this point, and you can use one leg or both legs at the same time. Now pressing in gently toward the back of the bone. This should feel like a bruise, not nervy or sharp. So pressing in toward the back of the bone. It should feel strong, but not too painful. Is that okay? Always watching mum's hand or face to see when the pressure's enough. Okay. So if it's painful, just back off slightly until the pressure's okay. Now massage this point very gently, just in very small circles. Just check whether mum prefers just plain pressure or little massage in circles, and whatever she prefers, just keep practicing that. This point is really useful when mum is sitting up on a fitball or on a chair, or even when she's on all fours or lying on her side. You can stimulate this point for around 20 to 30 seconds up to about 90 seconds. You're stimulating this point for around the length of a contraction or a wave or surge, whatever you like to call them. In the early parts of labour, contractions last about 20 to 30 seconds and up to about 90 seconds towards the end of labour. So you're stimulating for the length of a contraction. During early labour, you can use this point during every contraction to really help you get into established labour. But if it's the middle of the night, you might just want to rest in bed and wait until morning. For the first few hours of labour, use this point with each contraction. Or if the contractions have started to lose power, like sometimes happens with an epidural. If you do use it with an epidural, be careful not to bruise mum because she won't be able to feel the pressure. If you're using this point to help promote labour, you can stimulate the point for about a minute to a minute and a half and use it in combination with the other labour promotion points.
So in your workbook, you have multiple acupressure points that she has given us permission to use with you. And so these are other options. I like the one, like especially for pain on the hand. If anyone's used this, I've used this for headaches for a long time. But it's one tool for your toolbox of many to help support those regular contractions, okay, alongside the other things, right? We are going to touch on the pelvis, all right? So we're going to talk about it, and then we're going to give some foundation. Then we're going to table it. We're going to come back to the pelvis a little bit later, but I can't talk about some of the other ones until we have a basic understanding about our pelvis. And so we love the pelvis because it is so adaptable to labor and birth, but it also provides some structure. Now, of course, when we're looking at the baby fitting through the pelvis, what we're looking at is this hole inside the pelvis. And so I'm going to have everyone stand up. We got to keep you literally on your toes. Okay, follow along. And I want you to identify some of these structures on yourself. Because if you don't know where they are on you, then it's going to be hard to identify and know what's going on in the body on your patient. Now, the more pelvises you feel, the more anatomy and bodies you touch with consent, the better you're going to get at this, okay? And so on the back, you're going to find the back part of your pelvis. So if I reach back and I'm feeling for a bony structure, I'm going to show you this way. Okay, I'm feeling for a bony structure, and this is the back top part, the posterior superior iliac crest, okay? So notice where the top part of the pelvis starts on your anatomy. If you look at, I'm just gonna show you my belly, all right? So if you look at where it is on my body, we are literally at the nape of my abdomen, right? Like at my belly button. So a lot of times when you think about where the pelvis is in the body, we're thinking it's down here, when really it's more like up really high, right, in the body. We have to know this in order to identify the structures, in order to assess them and adjust accordingly. So notice how high the back part of the pelvis is. Now, I want you to feel forward to your hip bone. So on the front, like if we were to look at my belly, luckily right now I work out, so you can kind of see these like ab lines. I'm working on them, okay? But you feel for the bone on the front part of the pelvis. Okay, notice that is the anterior inferior iliac spine, okay? So we feel on the front part for like a little knobby part on our belly. Put your thumbs on the back part of our belly. This is first step, okay? And then if I were to bring my hands out, we can go above in just a second, okay? Notice the angle of my hands, okay? If we go above, okay, it's not angled this way, it's angled forward, okay? This makes a difference. We got to understand this, basics here, okay? So the pelvis is angled a little bit forward, all right? Not quite so much straight forward, like this, okay? It's angled down. So if we feel that way for one, then we got to go in the front, we got to find our pubic symphysis. So feel on your mons, right above your vagina crack, if you have a vagina, that you would feel that bony structure, okay? That's your pubic symphysis. It has cartilage in the middle that we'll talk about in just a second, but that bone, notice the difference in the angles of the pelvis of how much lower my pubic symphysis is from my hip bone, okay? Which means it's tilted, okay? We'll keep talking about that later, okay? So we have our pubic symphysis, and then I want you to feel your booty, okay? And feel in there and find, I don't have to stare at my belly much more, okay? Find your sits bones. If you do Pilates, yoga, a lot of times they'll say like adjust, or they'll like lift your butt cheek up so that you can kind of like access the sits bones. Sometimes it's helpful if you sit down and you kind of find it's going to be a more rounded, non-prominent, non-pokey, bony surface under and in your booty cheeks, okay? All right, so find those sits bones and notice where they are, all right, in there. That's going to play a very, very important role when we talk about the outlet of the pelvis, where the baby comes out at the end of it, all right? So sits bones back here, pubic symphysis in here, and then we have our beautiful sacrum. So inside the butt crack, our tailbone is going to kind of angle in. It's going to be like inside the butt crack. We got to know where that is. That's a lot easier to find because we have the booty cheeks coming together, and we can assume it's going to be in the middle of that. All right, now, what do we know about the pelvis? It moves. And so if and when you're pregnant, all of our cartilage, we also have a hormone called relaxin. It helps relax and soften out the cartilage in the body, which is why the pregnant people a lot of times get that like late pregnancy waddle, right? They feel a little less stable. They're more prone to injury. That's important, especially with our positioning. Okay, but what we know is that because it gets soft, it allows for mobility in the pelvis. Okay, and I'm obviously exaggerating to prove a point here, right? This matters because we want to work smarter, not harder. So if the baby's not in the pelvis, we want to open it up and go, come on in. And then once they're in, we want to lock and load them. And then once they're on their way out, we want to open the bottom part of the pelvis. We're going to talk through all of this. The pelvis moves. We love that. We can strategize what we know about the physiology to help set the patient up for success. Now, the other big one is this sacrum. So when we look at the way the sacrum moves, it's going to nutate and contranutate. That is the medical terminology for the cervix, or for the sacrum moving, right? When it nutates, it moves out of the way. If I go over here, that you can see that obviously if the tailbone is in the way and I'm trying to come out, right, it's not going to work as well. And so we want to move it out of the way and create more space when it's time for the baby to come out, okay? But also we would like to open the top part of the pelvis when we can. Now the sacral promontory, which is this little bone that sticks out, if the sacrum is nutated, meaning pulling out of the way, what happens to the top of the pelvis? The sacral promontory is going to cause a blockage, okay? It's not fully blocked, but it's going to get in the way. Make sense? Now, if the baby's up here, do we want this to get in the way? Do we want to prevent the baby from coming in and we're so worried about down here? No, of course not, right? Instead, we want to contranutate, meaning tuck that sacrum this way, and look what happens to the top part, meaning the inlet of the pelvis, okay? And so by knowing the physiology of how the pelvic structures work, we can set the patient up to create more space where there needs to be more space to help the baby engage, which ultimately gets it on the cervix, which ultimately helps with the hormone cascade. Make sense? Nutate, contranutate, we'll continue to come back to that, okay? So we're gonna put a plug in the pelvis and come back to that. Not literally, we don't wanna plug the pelvis. We want it to be open and available, all right? But let's talk about the passenger along the way, all right? Because it really does revolve around the passenger. Obviously, we need the passenger tolerating labor. So that's a given. That's a fetal monitoring class. We got lots of offerings for that as well. In fact, in 2 weeks, we have a basic fetal monitoring class if you're interested. Okay, but instead, I want you to begin to put yourself in the baby's shoes and go on the baby journey from the top down, okay? So for many of you, if you got a little pelvis guy, super smart name, but that's what we ended up calling it, so then we kept it that way. So you may have a pelvis guy in your stuff. You may also, if someone could find my pelvis guy, I actually don't see it. I'm gonna pass these off and I'll have the team look for it. But you also have a badge buddy, okay? And so when I was thinking about like all these visuals, because for me, when I'm at the bedside, I'm trying to determine what's going on, I'm literally like, I get really weird with my body. I use my body, okay? And so I wanna give you this tool because you also have a body that you can use. And often, once again, we think about bottom up. And so when you look at your pelvis guide, it's actually a top-down view. Thank you. All right, so you got your little baby. We also have a big one if you're interested. Those are in our shop. But the big one more just for teaching purposes, that if you're looking top down, I want you to orient it to yourself. So if we go above, we can see that if I'm holding it this way, I have the back where my sacrum is oriented to me because I'm going to use my body, and then pubic symphysis in the front. Okay, and then it's as if, morbid, but bear with it, that we just like cut off the top of the baby's head, and then what we're seeing is what's presenting in the pelvis going down. Okay, so that's how you're going to orient your brain. I know it's weird for your brain. This is not how we think. We think presentation into the pelvis from the bottom up, but for the sake of learning the way the passenger moves, I find it extremely helpful to be able to have this perspective in your mind. So you might get it right away, you might not, flex and flow, okay? But when we're thinking about the journey that the passenger goes through, I want you to imagine as if the baby was inside you. To think about, baby starts out high, it drops, and it goes through some movements. What are those movements? Going back to nursing school. If you had to be in nursing school, because I know they're like cutting it sometimes, all right? So your initial training, we learned about the cardinal movements, okay? And these are the way that the baby navigates the 43 different angles of the pelvis to what I imagine is kind of like a pinball machine where you're like boom, 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 boom. And they're trying to tuck and turn and help the birthing person to get themselves out as well. So what does it do? The baby has to engage. It has to descend into the pelvis versus high in the sky, okay? And then it has to flex. We see the cardinal movement so much, and I remember being like, okay, but actually this is really, really important. And lack of flexion of the baby's head is considered one of our potential malpositions of the baby that we don't think about a lot. So let's talk about this baby for a second. Okay, when we talk about flexion, what this means is that the chin is tucked. Okay, there's various positions of that head, right? There's like military position, which is like this, right? If we start to go this way, what starts presenting in the vagina on cervical exam, right? You start to get like a brow or a forehead or a face presentation. Okay, that would be truly a malposition of the baby, right? Not ideal. Most of the time, we're not getting a lot of face presentations. What are we getting? We're potentially not getting a flexed chin. So if I say flexed or I say tucked, same. We're talking about flexion in the cardinal movements. So in an ideal scenario, we want this baby's chin flexed. Why? One, look at the surface area of this baby's head right here. Can I go over here maybe? So if we look at the surface area of this baby's head, there we go. Okay, notice how wide the baby's head. So if this is what's presenting down the vagina, obviously flipped this way, but just imagine. Okay, there's this much surface area when they're in a military position, just not flexed. Okay, there's still vertex. We're moving with it. Okay, but what happens when they tuck? Notice now what the surface area is. Okay, so naturally, the physiology of the baby's head, the shape of the head is ideal when they are flexed. They're going to have to navigate less trying to get through and shove their way because you create less surface area. It's an easier slip and slide when their chin is tucked. How do we know whether they're flexed or not? Okay, one, they have to be ruptured because you have to be able to feel fontanelles. And so how many of us are experts at identifying the position of the baby by vaginal exam? I'm looking at your faces. You can be honest. Okay, this is a skill. This is not something that we're emphasizing. Okay, and so my first ask is whenever you get permission to check, if you are the one checking, if you're not, just ask whoever's checking, like, can you tell the position of the baby? We have to begin to also assess what do we think is going on with the baby. Okay, and we're checking for two things. One are the fontanelles, and we'll talk about the suture lines in a second. But first and foremost, fontanelles. The back fontanelle, posterior fontanelle, is a diamond shape. All right? The anterior fontanelle is going to be a diamond. All right? Now, my first tip for knowing whether or not the baby is flexed or not. Now, remember, how they're presenting down the birth canal is what you're going to feel, right? If they are flexed, what are you going to feel? What's going to present is that posterior fontanelle, which means you will only feel one fontanelle. Because, unless you're like really sweeping all the way around in there, but we're not feeling for that, okay? You feel where the cervix is, what's the presenting part, which should be a part of your exam, right? And if you can only feel around one fontanelle, you are likely flexed. Strong hypothesis. Why? Because if not, you go in, you feel, you're like, where is the fontanelle? If they have a lot of caput, you may not be able to feel this, but in general, you feel one, you're like, oh, other one. What do we know? Baby's probably not flexed, okay? So that's the best way for us to know. Now, if we're not checking inside, can we know by ultrasound? Probably not. Can we know maybe by the way that labor is going? Sure. And if labor is slowing and it's appearing to look like it could be moving towards a dystocia, or it is considered as dystocia, we have to consider that it's possible that the baby's chin is not flexed, okay? This is important, okay? And if we can set up the baby to be flexed, it's going to help support the physiology of birth because of the way that they work together, like a puzzle piece, okay? So what that means is there's a lot of elements, though, that need to align, right? The fetal head, size and shape matters. The attitude, whether it's flexed or extended. The lie, how babies lie. I'll show you a picture of that in a second. The presentation, vertex, military brow, shoulder breech, right? The position of which way baby is facing in the pelvis matters. We'll get to that when we talk about OP. The station and the engagement all matter. These are all components we should technically be assessing if we can. Now, when we talk about the lie, the other component is that there's vertex, yes, but the one I want to point out is an oblique lie. I had a patient who was really wanting like a natural birth and like had been doing all the natural things, working with her provider, whatever. She goes to the chiropractor. Chiropractor's like, I think your baby's oblique. And I go, I of course didn't say this to her, but in my mind, I'm like, uh-oh, because what do we know? An oblique lie means that they're not fully presenting like on the actual cervix, right? They're not engaged likely in the pelvis. They're like kind of off to the side. My first question, my assessment brain, my curious brain goes, why? Why isn't the baby more fully vertex, right? What is preventing it from getting on the cervix? And my next hypothesis was, knowing all of this, is that this lady's never going to go into labor if she doesn't get her baby on this cervix, right? And maybe, but maybe not. And guess what? That's exactly what happened. She did all the things, tried to get the baby on the cervix through chiropractic and other natural ways. Her water broke. She never went into labor. Ended up with a C-section. And what they found was that there was cord just literally everywhere. This baby was being suspended. It could not go anywhere, right? And luckily, a lot of times when we have those C-sections, it's nice to have that answer, right? That's helpful for their nervous system, their brain, in processing the event. But what we need to assess is the baby midline when you're feeling down on your Leopold's, which I'll talk about in a second, okay? So oblique one, transverse, obviously, and then breech. You check like, I don't think that's a head, all right? Obviously, we need to know that. So how do we identify the position of the baby, all right? First of all, we can inspect, right? We use our eyes, and we go, something's going on there. I'll never forget, I was working in triage, patient walks into me, and I'm like, again, not outwardly, but internally, I'm like, that is an interesting abdomen she's got going, right? And really it was like the baby, I was like, the baby must be really on one side of the uterus. Like, holy moly, because it was all over here. Sure enough, she had 2 uteruses, one of them being pregnant. So of course it was more on one side, right? And so my inspection knew immediately that looks different. Something's going on there, right? And sure enough, there was a reason. So use your eyes. What does it look like, right? Ask where the kicks are. Then we've got to use our hands, okay? And so I'm actually going to go here. I'll come back to the previous slide, but Leopold's is one of those underused and potentially very powerful assessment skills that has to be learned. We've got to start palpating these abdomens, again with consent, ideally prior to putting on the monitors, do a Leopold. So if we're looking at how to do a Leopold's, right? You start at the top of the uterus and you want to feel for what's going on up there. Ideally it's smushy, ideally it is round on top, right? And then I always ask, especially as a tip, because sometimes it's hard for me to identify between a head and a butt, but what has your baby been? Has your baby been head down, right? And so if they've been head down and they, then you can loosely hypothesize it's probably a butt, okay? Now, mind you, a booty is gonna move a lot more than like a head would necessarily, okay? So you can maybe a little more wiggly in there, right? So we're feeling for a booty. Then I'm gonna use both hands. I'm gonna feel back and forth along the abdomen, and I'm looking for the fetal back. Now, if I find the fetal back, okay, it's going to be firm along there. I can kind of find that firm surface tracking from the fundus down the side until I kind of trace it to imagine what's going on in the body. And then I'm picturing it on myself from the top down. I'm saying, okay, it's on the left side. I'm feeling this back over here, I think. Then you're going to check it by feeling on the other side, because naturally, if there's a back on one side, what's on the other side? All the limbs, little nubbins, right? And it's kind of smush. You're like, oh, and then boom, pops out a boom, right? And they're like, leave me alone. And all of a sudden you start to feel those little nubbins of a hand or a foot, okay? And you can confidently say, I think it's a limb over there. And I feel a back over here, so I'm feeling pretty good that I got a back on the left side and the limbs on the right side. What does that mean? The back of the baby, for the most part, is going to align with the occiput, right? Unless the baby's all twisty-turny in there, which we're not going to know, and you can make the assumption that the back is aligned with the occiput, then I know where is the occiput of this baby's head. If the back's on my left side, on the literal side, we're probably L-O-T, right? Now, the fourth maneuvers are down here, and you're feeling for the presenting part, right? Is it bellotable or not, right? This is a trick of like if the baby's engaged or not. If you feel on your pubic symphysis and you go right above, it should be smushy unless you're pregnant and the baby's engaged, okay? You can do this on them too, or have them feel. Right above your pubic bone, is it smushy or is it firm? And they're like, oh, it's so firm. Why would it be firm? Because the baby's there, right? That head is now in the pelvis, right? How high or low? We don't fully know, but we know it's engaged. Versus bellotable means you can loop, kind of like bellot it up. I don't know if that's a word or it applies, but you get the idea, right? It's like bloopy. Okay? So we want to know and we want to try using our hands. This takes skill. It takes a lot of palpation to really learn this. By a show of hands, how many of you feel super confident about your Leopolds? I see a midwife raising their hand, and then I say, no way, Jose, right? Of course, because this isn't normal. We don't do this. And then you have monitors in the way, right? If you're going to do a true Leopolds and you're really assessing for position, you're probably going to have to take off your monitors, right? And you're like, that can be annoying to the patient. At bare minimum, before you put the monitors on, what are we doing? We go, and then you feel for firmness. You're doing like a very modified, non-official Leopolds by going, oh, it's firm over here, left side, right? And that because we want to find the fetal back in order to place the monitors. Make sense? So my ask is just begin to palpate. Now, here's the trick, especially for those admissions, is before you put the monitors on, do your Leopolds. And you might be like, I have no idea, right? But make a hypothesis. If all you feel is smush and nubbins popping out at you, where's the back? Behind. So you probably have an OP baby. Are we stressed? You'll find out later. Probably not. Not yet. They're not in labor, but we're paying attention. That's a part of our assessment. It needs to be documented. Now, before that Vertex ultrasound comes in, do your Leopolds. And then when they throw the ultrasound machine on, just say, hey, so-and-so, can you identify the position for me? And very quickly, potentially, they go, oh, yeah, no problem. Baby looks like they're LOT. And you go, oh, I got it. And then you have confirmation. Now, if it's wrong and they're like, no, the baby's OP, you're like, okay, go back and feel the belly again and go, okay, this is what OP feels like. Why would that make sense? We got to envision what's going on in the abdomen. Okay? So if we go back to the passenger, we got to palpate. We can do it by cervical exam, right? As if they're ruptured, they give us permission. It's appropriate for the plan of care. We want to feel where the suture lines are. We also want to feel where the fontanelles are. We also want to feel where the suture lines are. I'm going to go over here. So we also have these suture lines. The sagittal suture in general should be also midline. Now, if it's coming down, and let's say the baby's flexed, it's coming down the vagina, and you feel, and you're like, oh, I got one fontanelle, yes. But you're feeling for that suture line, and the question is it midline in the vagina? Okay, because if it's not, and I'm feeling like, oh, it's off to the side, what are we dealing with? We do it this way. Okay, this is called asynclitic, where the baby's head isn't here. Okay, it's kinked to the side. All right, we want to note that because we have some things we can do about it as well. Any of those malpositions are going to potentially set the patient up for a slower labor and are a risk for dystocia. This is why our assessment is so important. And the number of times I've been at the bedside, I'm not checking the patient, and I'm like, can you tell if the baby's asynclitic? And they're like, I'm not sure. Okay, all you're feeling for is that suture line. Is it midline or is it off to the side? You might say, like, it might be a little bit, or we'll push for 4 hours. Somebody will check and go, oh, actually, I think the baby's asynclitic. It would have been so helpful to know that prior to pushing, okay? Because there are potential things that we can do to help adjust, or at least set up the body to be fixed, all right? Ultimately, ultrasound is the gold standard. Now, if the baby is not flexed, here's your first potential intervention. I'm gonna call Hannah to the stage. She's gonna be our booty model for today. We'll get to know her pelvis very well. Okay, this is Hannah. She is our director of strategy and also my sister. Can you tell? So you get to meet the fam today. All right, so I'm gonna have you just get on all fours, your head this direction. Just relax for a second. So what we're doing here actually is that if the baby is engaged, right? And what happens when they're engaged is baby's low. Once they're in the pelvis, they're like, there's not very much room to wiggle around, to adjust and fix themselves. Okay, and so the goal is that we actually have to create some space in order for the baby to have more room to tuck their chin. One of the theories is that actually as the baby comes down, that the sacral promontory helps propel the chin forward, which I think is so interesting. It's a theory, okay? So the goal for encouraging flexion, if you identify that the baby is not tucked, okay, get them into a puppy pose, all right? So this is a yoga move. And so what we want is we want to use, actually, I keep putting my baby down, but I need them. We want to use gravity in the pelvis to allow for the baby to disengage a little bit. Okay, I'm getting consent. Can I touch you? Yeah. It is my sister, but we're still always asking. Okay. So when we look at the pelvis, if the baby is not engaged, still potentially a good move. And then you can do some booty shaking while you're here as well. But the goal is you want to back them up just a little bit to encourage, and then ideally add some movement to encourage the baby to have the space to tuck their chin. Okay, because the more engaged they get, the more stuck they're going to be in there. And so you have them on all fours. This is with or without an epidural. Obviously, you're assessing to know what's safe or not. And then I'm just going to have you drop your shoulders as low as you can with your booty as high in the air as possible. Okay. Now, so she is fully tipped. In this case, I'm going to help her breathe. Anytime that they're on all fours, this is a massive opportunity to work in your office, right? And we're going to learn how to do this, assessing the ligaments. I'm seeing what's going on with the pelvic floor. I'm seeing if there's any tension. I'm softening. I'm doing some pressure. I'm doing some massage. I'm helping them release and calm, helping them focus on their breath. Just relax. Let everything go. I'm watching my energy. Okay, I'm here for about 10 to 20 minutes if they can tolerate it. I don't usually suggest a full inversion. I don't think you need it. If they need support, you could place a peanut ball under their legs here. I love using a peanut ball for this reason. So then you kind of like sneak it under so they have some support. Make sure you're giving them pillows and you help them relax here for I'm gonna say 10 to 20 minutes, okay? And the point is what we're doing, and people are always like, what about a cord prolapse, right? Because you're like, boom, now cord. Okay, the amount of movement that happens in this position is so minuscule. And we relate it to, this actually came up in a class. So it was a participant that gave us this analogy that I think is so brilliant. It's like when you go into a parking space and you're kind of like, well, that's embarrassing. Like you look all like off, right? What do? You're in and you're like, oh, hold on. And it's just like a little whoop so that you can realign to the pelvis. It's a great reset. It also obviously pulls on the round ligament, pulls on the lower uterine segment to potentially create more space for this baby to be able to tuck their chin. Can I get a thumbs up? We tracking? I think you're free for now. We're going to be back and forth for a little bit, okay? Thank you. All right, so then we have to understand not only the cardinal movements, but what is the journey of the baby's head through the pelvis, all right? And so when we look at the action of descent, okay, this was revolutionary for me. When I got this, I was like, oh, it all makes sense. Okay, and then we're going to loop back to it later. So pay attention. You also have this on your badge buddy, which I lost, but on your badge buddy, there's this little, like this little guy down here, okay? And you also have your head. So the way that you use your badge buddy is you can pull out your head and then imagine based on your pelvis where the head is, all right? So you're imagining how it's presenting in your pelvis on the go, but you also have this as a reference on your badge buddy, okay? So when we look at the normal way in an ideal scenario that the baby's head matches up with the pelvis, the first step is engagement, right? Baby starts out high and then it engages. Now, let's just say baby's not flexed and it's not perfectly round because we are going to get a much more round presentation of the head when the baby is tucked, okay? But for the most part, it's not a perfectly round head. It's not like a balloon or something. There's going to be a little bit more of an oval shape to the head, right? So imagine we have anterior fontanelle, posterior fontanelle. All right, so this is now our baby's head. I'm gonna use it to demonstrate, all right? And then when we look at the way the pelvis works, all right? Now, if we go here and we look at the top part of the pelvis, which is the inlet, look at the shape of this pelvis. And let's just say we're contranutating, so we have a perfectly oval top, okay? So if we look at the way that the baby's head and the pelvis fit most perfectly together, as the baby engages, is the baby anterior or posterior, kind of more oblique, or is it going to be side to side? Notice this circle aligns perfectly with a baby that is in a transverse position. So the way that the top of the baby's head aligns with the inlet of the pelvis, the top ring of the pelvis perfectly, is in a transverse position. Okay, so when you have your patient that comes in and they come from the office and they're like, my doctor told me my baby's transverse, or you do your Leopold's on admission and you find a back on one of the sides, most of the time it's going to be the left side, and you find that back and they're like, oh, my baby's not anterior. Are we stressed? No. In fact, we have an opportunity to be like, that's amazing. It's literally perfect. This is exactly how the baby is aligned in order to be able to settle into the pelvis. This is exactly what we want. So in an ideal scenario, with the pelvis and the baby lining up like a puzzle piece, babies enter in a transverse position. Okay? Now, as they descend, you're going to get an internal rotation in your cardinal movement. So what does this practically look like? Now, if we look in the pelvis here, what are we checking for if we're going up for a vaginal exam? We're checking for our ischial spines. That's our landmark. Let me see if I can get you one. See that? Right here. It's your landmark for how high or low the baby is by vaginal exam, okay? This is also the smallest part on the pelvis that the baby has to navigate through. When we're pushing, I always talk about it's like a speed bump, where they got to get up and over the bone. When they're like, get under the bone, like obviously they're getting under the pubic bone, but they're really getting past the ischial spines. Once they're past that, they can't go back anymore. So this being the smallest part of the pelvis, if they're entering the pelvis in a transverse way, with this being the widest part, what's going to happen? They are going to hit the ischial spines. So what does the baby have to do in order to navigate the normal anatomy of the pelvis? They have to rotate about an eighth, meaning they internally rotate. Ideally, they internally rotate towards the front. So the occiput rotates towards the front in order to navigate past those bones. Can you see that? So I have bones here, okay? Baby comes and hits those bones, And instead, it goes a little crooked so it can go past the ischial spines in the pelvis. That's your internal rotation. So baby enters transverse in an ideal world, enters transverse, begins an internal rotation, which aligns with our cardinal movements. And then on the outlet, okay, and I flipped it so you can look top down, okay, the baby's head turns, and then we're looking this way, right? So baby's now, get this right, okay, baby has internally rotated and made it past the ischial spines. And then if we look at the outlet, meaning the bottom part, if we are nutated, we move the sacrum out of the way, which we have to have mobility and the ability to move the sacrum out of the way, right? That oval shape is anterior, posterior. And so the longest part of the head rotates from internal rotation to out, the outlet. See that? So the surface area, I'm not bonking up against anything. Now, if I were to stay transverse the whole time, I'm going to hit the ischial spines on either side. And then I have all this space on either end. So ideally, the baby finishes that rotation and can come out the outlet. Okay? Does this make sense? That is the normal progression. So baby descends, internally rotates, and then comes out with a full out. Okay? And what that means is, in an ideal world, right, the posterior fontanelle, meaning the position of the baby, ends up anterior at birth or on the outlet. But it doesn't usually start out that way. Okay? We have to understand the normal so that we can identify what's abnormal. Okay? And if we are going to strategize the pelvis and the anatomy and the physiology, we also have to know where we're trying to go, right? We just want to wiggle baby out. Well, if baby's transverse at the inlet, at early labor, they're barely in labor yet, are we worried? No, we're not fixing what's not broken. But if we're 6 centimeters and we're identifying that the baby is high, but they're posterior, would it make sense that it's going to make it harder for this baby to progress in labor and come down? Because the anatomy's in the way. And so if we know where the baby's supposed to go, then we can help to make suggestions as to where the baby needs to get in order to set the pelvis up for success. Does this make sense? Okay. So one of my acronyms I use is as if, okay? When we are moving into the land of position changes, y'all, okay? lay in the ground floor for it. All right? So when we go to talk about position changes or interventions or how we can help, the first thing we need to do is ask about their sensations. If they do not have an epidural or prior to their epidural, that for you is one of the best nursing interventions to give you information to be able to figure out what's going on in the pelvis. We say change the game. For me, when I'm at the bedside, my patients don't know this, but I am playing the game. And I am like, where's the baby? Where does it need to go? What's aligned? What's not? Where is their restriction? How do I set them up? Right? And I'm constantly asking those questions. One of the best ways to get information is based on their sensations. Their body will tell them, right? If all of a sudden you see a patient that's just like, I just feel like I gotta do this, right? Or there's something going on here. What's happening? You can make an assessment that like something's likely banging up on that hip, and they're using their sensations to help potentially rotate the baby and get the baby to navigate the pelvis, right? Their sensations are so important. Now, if they don't have sensations, then you're using your assessment skills, but they might even have sensations with an epidural, right? We've seen that. So we got to ask about it. And then we got to trust their sensations. In labor, the rule is whatever feels better for them is the way to go, because the way the body's set up is to not only help you cope, but give you those cues to help tell you, whether you can identify it or not, what needs to happen in the body. So I'm like, I just got to get my leg up. What's happening here is I'm opening up this right part of the pelvis, and likely that's going to help this baby rotate. Am I here for the whole labor? No, we see this, right? I have to do this, or I have to be on all fours. I have to. And then something changes, and no longer am I there. Now, something changes, right? And that instinct, that intuition is guiding the laboring person in the way to help get this baby out. If they have sensations, it is the most powerful tool, and it is paramount. All your knowledge, great, have it in your back pocket, but if they are following their sensations and they are coping, we're going with it, okay? Then we want to, of course, identify their concerns. What's going on with their psyche? Is there anything that I can do to help calm the room? Okay, and once that's there, you want to fix it. If there's an interruption, if there's something going on, things are slowing down, we want to give options based on physiology, all right? Which leads us to the big question, which is, how do you know which way to encourage your patient to turn? Okay, and we're specifically talking about left and right position. So this is especially important for epiduralized patients, but also non. Okay, and I say encourage your patient to turn because we're going to offer encouragement one direction. I have an idea. What I'm noticing is this going on. And I think if we can put you in this position, if you can tolerate this position for a little bit, it's going to open up that part of the pelvis and hopefully help make that final rotation and speed up your labor and set you up for success. Are you willing to try? Right? We're encouraging them, not saying you need to do this, right? And then we're putting the control, the agency back in their hands. But it also is how we present it. Because if it's like, do you want to try this position? I think it'll help. That's very different than what I'm seeing here is, and I want to help you, and I have this tool. And what it's going to do is open up this part of your pelvis, which is where the baby needs to go. So if you can tolerate it, I think it's really going to help your labor. Right? Very different. They're going to be much more open to that because one of the biggest barriers I hear is, well, the patient doesn't want to do it. For me, that's a question of the provider, whoever's talking to the patient, of like, how are you presenting the information? Right? And again, they might be like, absolutely not. I am not. And then shared decision-making is key. And you go, okay, no problem. And then you go, what else can I do to help? Because you got lots of tools. All right. So we're going to ask this question. How do you know which way to turn the patient? Okay. / encourage the patient to turn. Okay. This is specific for left and right positions. Now, this is the moment I put a door here because this is an open door. If you are tired, if you are distracted, okay, this is the part in the class that is most confusing for people. It is the hardest thing for people to get. So I'm going to suggest, like, take a deep breath, shake it out, because if I lose you here, you're going to slightly be lost for the rest of it, for one. And I don't expect you to fully get it because it takes like a whole, like, in your brain. For me, even when I'm at the bedside, I'm like, how does it work? Okay, so because of that, I have given you this clip from the class forever in your account, right? Because it was stressing people out so much, like, I don't know, and all these questions. It takes some time to marinate, okay? So all I want you to do today is take it in, try to conceptualize it, begin to build, and then you can always go back to this recording, and then you can also go back to the baby clips, the baby rules clip in your account that will not expire, okay? It's there forever, my gift to you, okay? So that you can begin to conceptualize what I'm about to tell you, okay? We ready for it? It's good stuff. Makes me excited. All right. When we are talking about our position changes, we have to understand there are two dynamics functioning with each other, okay? There is the anatomy of the pelvis and all the pelvic structures, and then there's also the way the baby moves. And those two components are interacting with each other in order to help get the baby out. So we have to understand how the baby moves. We also need to understand how we adjust the anatomy to support the baby to move. We good so far? I'm looking at your faces, Cindy. Okay. Perfect. All right, so we are going to talk about the level of the pelvis in just a second. We're going to end before lunch on that. But we're going to focus on what I call the baby rules, the way the baby navigates the pelvis. And by baby, I am always talking about the occiput. Now, mind you, the occiput is the presenting part. It's the first part that guides the whole baby. So if I'm talking about the baby is here, I'm talking about the occiput, meaning where the occiput, this fontanelle, is in relation to the pelvis. Okay, so keep that in mind. Your baby rules are that the baby's head will follow the path of least resistance. And this is sort of common sense, okay? If I am walking towards a wall and there's a door over there, which there is, I'm going to walk towards the wall and bang into the wall? No, that's resistance, right? I'm going to go that's the right way. There's less resistance over here. I'm not going to pound my way through a wall, right? Instead, I'm going to go this direction, okay? We have to understand that because, especially with our position changes, if there's less resistance in the anatomy of the pelvis, baby's going to go that direction. So we have two sides of the pelvic floor. We're going to talk about this, right? One of them is super restricted. The other one's super soft. Where's baby going to go? Super soft. It's going to be like, well, it's easier over here. What did I just do to my head? Asynclitic. Okay? So the goal is we want to optimize the anatomy for the baby to be set up to go through the cardinal movements. Okay? But naturally, the baby's going to go the path of least resistance. They're going to go this way if it's soft. So we want to keep the environment less resistant. Make sense? The other rule that accompanies this is that the head is the heaviest part. So the head and particularly I want you to envision there's like a weight in the occiput, okay? That helps me. And so the occiput is always going to fall towards gravity. All right? So gravity and path of least resistance are what help move this baby through the pelvis alongside some of the other things, but these are our key baby rules. Now, when we look at our side lying position changes, there are two types and classifications that I have made up related to how we position our patients or how they position themselves, all right? So if we look at where the hip bones are, I'm gonna use myself for this for a second, okay? And we look at where, like, you imagine like where the acetabulums are or like where the femurs connect, okay? But I'm gonna use this as my landmark, all right? There are stacked positions and there are open positions. That's my terminology of how I use them, but we need to understand the difference. So if I am in a stacked position, you can try this when you have a second, your hips are directly on top of each other, okay? So if we go above, typically, if you were directly above, you wouldn't be able to see this bottom sticker because I'm on my hip. Meaning if I'm in a stacked position, I'm also like, my bottom hip kind of hurts because I'm directly on top of my hip bone. You think about some of our positions we use, a lot of them are stacked positions based on where the hips are. Are they directly on top of each other or are they open? Okay, and open is anything else. So it's a shift and all of a sudden I'm like, oh, my hip bone feels so much better. And I'm back this way, I might be turned this way, right? And so if I'm back, let's go this way, no longer can you not see my two stickers because I'm tilted, okay? Now, the other key here is that based on the side that I'm on, the bottom hip is always the stable hip. It's the one without mobility because the ground or the bed or whatever I'm on, right, is stabilizing it. It's holding it steady. And so when I'm opening a part of the pelvis, the other opposite side is the one that's going to be the open side. Okay? Stacked positions versus open positions. Could be back, could be forward, they're just not stacked. Okay? So if we look at the way that the baby navigates through the pelvis, okay, or we think about it super logically, like common sense here. If we look at the occiput, which right here, if I were to look this way, it's going to be LOP. See that? So it's on the back part towards the sacrum. If we are going to try to rotate this baby so that it aligns with the pelvis in the best way and eventually rotates to anterior, which way would we ideally want this baby's head to turn? Okay? It's always confusing when you're in the chat because it's like, technically, what's the fastest way to anterior? Do we want to rotate it fully OP, then ROP, ROT, ROA, OA, or do we're already LOP? Do we want to go LOT, LOA, OA? Much quicker to rotate left, okay? We want to set up for success, the least amount of work. Yes, to LOT first, exactly, okay? So if we know where the baby is and it's LOT, right? I know my goal is to rotate the baby LOT first, exactly what Robin said, because it's the quickest way to anterior. We're not also potentially getting the baby to OP and then potentially getting stuck there, right? So we have to know where the baby is to know which direction we want to go based on how the anatomy works, okay? So the easiest way to anterior is left. We want to move that occiput left. Now, how does the baby's head move? If we go back to our baby rules. 1, our baby is going to move by the rule of gravity in a stacked position. Why? Because you're stabilizing the way that the pelvis works. You're not opening anything, it's just here. So if you're not moving the pelvis and creating space by opening and wiggling the pelvis, then the pelvis is stable, so the rule that overtakes is gravity. So in a stacked position, you're imagining, if you know where the baby is, you use the rule of gravity to rotate the baby towards the ground. I'm going to build on this, so just bear with it, take it in. Okay? Now, for an open position, what we're doing is we're actually opening up and creating space one direction, saying, this way, come over here. Okay? So in an open position, we have the stable hip. The one we mobilize is the direction we're creating space for the baby to go. So if my baby is LOT, and imagine it on yourself, you can use your pelvis guy, think about it, okay? And I'm gonna say, it's time to lay on your side. And this baby, let's say, is only tolerating the left side. Am I gonna be, in order to rotate the baby to LOT, am I gonna be on my left side, and I'm on my left side, am I gonna be open or stacked? Where's my hand? Will you throw me the baby? Actually. Thank you. Okay, I'm going to get a baby. Don't you worry. Okay, so I'm in a stacked position. My baby is towards the back of me, down here. Okay, if I'm stacked, gravity works, so the baby's head is going to turn towards the ground. Meaning, what did it just do? It just turned LOT by going left stacked. Now it's time for another position change. And now I'm LOT, but I got to go on my right side because we're not just staying in the same position all the time, right? And all of a sudden I go to my right side. Okay. And now I'm over here and I'm hoping to rotate that full left side rotation. So instead of stacked, I'm going to open up the hip and I'm going to go, baby, there's so much more space here. Find your way of the occiput. Okay, and all of a sudden I'm no longer stacked. I've created mobility, and it could even be here, right? Depending on the level of the pelvis, which we'll get to create mobility on that left side, no longer stacked, saying path of least resistance, this direction, to help create that final rotation. Okay, so what this means is, I made a cheat sheet for you, don't you worry. The keys are, we have path of least resistance, and then we have gravity, okay? They align based on types of positions, stacked or open positions. The leg you mobilize will create space that direction, making the baby favor it. Meaning, if you want, and this is where people get super tripped up, okay? If you want to rotate the baby left, you actually have to lay on the right side, but mobilize the left side. So if the baby were LOT, you would go left stacked, right open. By right, I mean you are laying, it's like the way you chart your positions, right? They're on the right side, but the open leg is actually the top leg. Okay, are we tracking? We okay? Are we panicking? I hope not. Okay, ultimately their instinct matters most, all right? So let me do this on the right. Now, if they're fully OP, ideally, and you can only go left or right, ideally, the physiology and the common sense of the way that the body works, ideally, this is why a lot of them are feeling like they need to get on all fours, right? Because what happens on all fours, and again, these rules are really left and right-sided rules, because you get on all fours, and all of a sudden, I have all my rules at my advantage, right? I have gravity pulling the occiput anterior, right? I have full mobility of my hips. The sacrum can do anything it needs to do, nutate or contranutate, right? I have that full freedom of movement, okay? Coincidentally, you also have the best perfusion to the uterus in an all fours position, which is great. That's why we turn them on a D-cell and they fix themselves on a D-cell, but we can't put them there for position changes. Okay, so when you get on all fours, you're allowing for free movement, and that gravity and the path of least resistance really works to the baby's advantage. Okay, so obviously if baby's OP, we're probably thinking if we can get on all fours, great, but ideally we want to know which direction the baby is so that we can go the shortest way to anterior. I'll never forget, I had a client who, she didn't really have a dystocia, but I was just, of course, like trying to like help her and speed things up. Shorter length of labor, she was over it. She had an epidural. I remember looking at her belly and being like, I feel like it's over on the ones. And you can kind of sometimes see it the better you get with your eyes. There was like a protrusion this way. It was kind of like wider a little bit. And I felt, and by Leopold's, she felt LOT. So I'm like, okay, if based on what I know of the body, I know probably baby's high. I think she was probably 6 centimeters. And I'm like, okay, she's probably like negative station. Right? If I know the way I want to go, I want to turn this baby left. So we did some strategic position changes using these rules and another. Okay. And by the time I had gotten her back up into like a sitting position where I could actually feel, her belly was so far forward. And you know those basketball bellies, right? That they're just like so protruded. You can feel the back was right smack dab in the middle. And of course she had an epidural and I was like, I was like, you feel anything? She's like, yeah, I kind of feel rectal pressure. Of course, I like change her chucks and she had lots of bloody show. And I'm like, of course. I'm like, my guess, and I didn't say this out loud, but in my head, I'm like, my guess is she's complete. Because why? She started here, made the rotation, and now the baby was in an OA position, which fits the pelvis when they're low. And sure enough, of course she was, right? And so we start to be able to piece it together and make those hypotheses. Am I always right? Absolutely not. Sometimes I'm like, I do not know. I do not know, you know, and I had that recently with a client that we did everything. And I'm like, if, you know, like, and I don't promise my clients anything, but I'm like, you will have my knowledge and I will do everything within my power to help set you up for a vaginal birth. Like, right? That's what we want to be able to offer everyone. Sure enough, she ended up with a C-section. They went in and there was endometriosis everywhere. So much restriction in her pelvic area. Okay, this baby wasn't coming down, but we know we did everything, and she was so grateful to have done everything. Okay? How we doing on this stuff? Did this make sense? Is there a question? Let me see. So for LOT, you can do flying cowgirl on left stacked, and then rotate them to the right, semi-prone, open on the right, reverse if they were ROT. So for LOT, flying cowgirl, and we'll talk about this in a second because we're going to build on this to the whole other side. So we're talking about the baby side, but we're going to talk about anatomy in a second too because you're going to piece them together. But yes, so you would go left stacked. Flying cowgirl is a stacked position. You can always adjust it if you need to, but in general, yes. And then you would go right with the leg open on the left, right? And then reverse if they were ROT or P too. Works for P as well. Okay, your rules are there. They're in your workbook. Okay, more than anything, you can memorize these rules, right? ROT, ROP, right stacked, left open. LOT, LOP, left stacked, right open. More than anything, I want you to really conceptualize it. And when you're at the bedside, literally, I do this where I'm like, okay, palpate, and I think blah, blah, blah. I'm like, okay, so baby's here. So then like if I go here, it will go there, and then I can, okay, and then we'll flip and we'll go here based on pelvis, right? If you understand the physiology, it's like the same with pathophysiology of any disease process. You can start to hypothesize potential nursing interventions that have potential merit, right? Left open, so peanut ball or semi-prone. Yep. Open the left, not left open. That's the part that gets very confusing, okay? When we're saying what side they're on, it's what side is hitting the bed, but not necessarily what we're opening. So left open means they're on their left side, open, meaning their right side is open. Does that make sense? We feeling good? Take it in. Sit in it. Okay. Let me see. Okay. So again, the goal would be, if they're ROP, we want to rotate to ROT, to ROA, to OA. Same goes the other way. If they're LOP, LOT, LOA, OA, along there. So when you're using your little pelvis guy, what this looks like is I'm palpating, I maybe Leopolding, I maybe got an ultrasound on it, and I know that this baby, they are an induction. There's no labor. One, I'm not stressed. That's a bad example, because at that point I wouldn't really do anything. I'd wait to assess, really to make better decisions once they have contractions. So let's say they show up, they're 4 centimeters, they're waiting for an epidural, okay? And I assess, and this baby is ROP. Okay, so on your pelvis guy, hold it to you and make that little triangle fontanelle on the right side of you. So I'm here and I'm like, I got it, okay? And I look and I'm like, I want this head to rotate to the right to get to anterior. I at least want it to help get to transverse. And that is the first goal. Why? Because that's the best way to align the baby to be able to settle into the pelvis, especially if they're high. Okay, so if I'm going to go from ROP to ROT, right, I'm going to turn stacked, and when I go stacked like this, head's going to go to gravity. Okay, down. And then when I flip, head could go to gravity, right? So you can also use it that way, where if I'm like, now I'm ROP, where's head going to go to gravity? Is it going to go to the right? Unlikely, actually. So the question always comes up, can I cause OP by the position changes that I suggest? The answer is yes, okay? And you'll find that out later in the class too, okay, by some statistics, okay? So instead, my head is gonna start rotating OP. Now, if I give it enough time and or I get really lucky, could it do a full rotation down to gravity to end up LOT? Sure, maybe, but pretty unlikely. And if we want to set them up for success, instead, we need to use our brilliant brains to really strategize and go R, right, stacked, get them there. And then when we get to left, we open up this side of the pelvis to say, so much space, come this way, to anterior. Okay? You're going to get it. If you're like, okay, just sit and breathe. Okay, we got it. All right. You feeling good? Stacked on the right. For ROP, yes, stacked on the right. Totally. Okay? So when we think about the passenger, how can it be disrupted? All right? We have to ask what's getting in the way. It's the same with that oblique lie, right? Like I'm saying, what is going on in there to get in the way so this baby doesn't fully present? Is it the pelvis? Could it be other surrounding structures like the pelvic floor ligaments and fascia, which we're getting into? Maybe. The ultimate goal for our passenger is to create an environment for them to be able to accomplish the cardinal movements. And if they're not, we need to be able to assess and know, one, where's the baby? Where does it need to go? And then suggest potential position changes or other nursing interventions, which we're getting to, but in this case, it's going to be our strategic position changes. When I say strategic position changes, what I'm talking about is you're actually strategizing the baby rules in relation to the pelvis, which the pelvis has rules too, which I'll show you in a second, okay? You're strategizing those position changes, okay? And maybe you're doing all of that and still it's not working. Position changes are not the end all be all. I know we love them. I know they're super effective. They're one of the only things with pretty solid evidence, okay? But there might be more going on inside the body. One of them being that, this is like a very slight plug as an awareness because we're super smart, is this concept of right obliquity. So when we look at the power or the shape of the uterus, okay, it's not a perfect round structure for most patients, okay? About 80% of people have this thing called right obliquity. And what that means is that the baby will likely favor the left side. So just start paying attention when you're doing your Leopolds and you're seeing what position babies are coming out in even, right? A lot of times you're gonna find that fetal heart rate or you're gonna feel that back on the left side, okay? And the idea is this is likely has to do with some right obliquity. Now, what this means is that you have a uterus that's not perfectly round. And so on the right side, it's a little more flat than as rounded on the left side. Now, when we think about what impact this potentially has is that the baby shapes to the uterus. So if I have a baby that's presenting inside of me and the back is on the right side, so I palpate and I'm like, I'm pretty sure this baby's on the right side, it's a noted type thing, okay? But what do we know? If they have some right obliquity, the uterus is going to help them with the process, okay? And so if we know that the back shapes to the uterus and there's some flatness on this side, what ends up happening with this baby's chin? It's military presentation. It's not flexed. Now, if the baby's presenting on the left side, which is much more round, what naturally happens is it shapes to the anatomy. And then what do we get? A tucked chin. Okay? And so it's not something we're stressed about. It's not a malposition. It's not like, the baby's on the right side. Ultimately, they present transverse no matter where they go. But if they're presenting on the right side, it's an awareness that we might end up with, we have a more of a chance of a less flexed chin. Okay? Just wiggle them. More motion is lotion. Okay? And when we're assessing the abdomen, which I normally don't even talk about this, I kind of skip over this part, you may want to ask about trauma, right? Because if they have some fascial restrictions, which is scar tissue, they've had an appendectomy, they've had injuries, right? Ideally, the uterus moves freely in the abdomen. If you kind of like, when do we do this? When we're trying to wake up the baby in a decel or something, or like, wakey, wakey, you're kind of flat. And you're like, oh, right? All right. And so it should move freely in the abdomen, right? And if it's kind of stuck, there's potentially some restriction in there. We need to go, fascia, okay, which we're getting to fascia in a second. All right. So then we get to our ligaments. So we're building on the 5 Ps in this case to our ligaments. Now, what are ligaments? They are short bands of tough, collagen-rich, flexible, fibrous, connective tissue that connects 2 bones or cartilages or holds together a joint, all right? This is our stabilizers of the pelvis, right? It's one more area of stabilization, right? Now, there's typically 2 sides to every one. So you have your right ligament and your left ligament based on whatever ligament you're talking about, right? Now, the key here is they are infiltrated with smooth muscle fibers. And so what that means is that they can stretch, they can contract, and they also can spasm. Okay, I see a question I'm going to pause on. Does the same idea apply on all fours or lunging? If the right leg is forward, does that create more room on the right? Ding, ding, ding. Yes, baby rules apply. So if you mobilize the right side, you're creating more space on the right side. Yes. Okay, so when we talk about our ligaments, they can spasm, they can contract. They also stretch a lot in pregnancy, which causes a lot of our like round ligament pain we see in triage, right? So knowing this, they're not really meant though to stretch like a muscle, for instance, right? They're infiltrated with smooth muscle fibers, right? And so what that means is there can be restriction. Any restriction in the pelvic area, now we know is a we want to try to create the most space possible. All right, now 2 of our main ligaments I'm going to highlight here are our sacrospinous and our sacrotuberous ligaments. So if we look at the pelvis, and I decide which pelvis to use, I'll go with this one still. Okay, now it's with the word, all right? So sacro meaning sacrum, so it innervates at the sacrum, and it goes to the spinous, meaning the ischial spines. All right, so this is going to be more internal. We got to know our anatomy so we know what to assess. Internally, there is a ligament that connects from the sacrum to the ischial spines. Let me go this way. here, okay? Ischial spine, right here, connects to the sacrum. Okay, so if we look this way, we see that connection. Now, can we palpate this from the outside? No, we cannot, right? This is gonna be more internal. When are we palpating ischial spines? On cervical exam, okay? So I'll come to that in just a second. So that's our sacrospinous ligaments. Now our sacrotuberous ligaments are also innervating on the sacrum, but they go to our ischial tuberosities, our sits bones. Okay, now these, can we feel? We just did, right? So if we know where the sacrum is and where the ischial tuberosity is, meaning the sits bones, we can know about where those ligaments might be, okay? And the goal is that one, they're soft and spongy, that they're flexible, not too flexible, right? That we're tearing them or something. But we want them also equal, because knowing our baby rules, if there's restriction on one side, where's baby gonna go? This direction, right? And life causes restriction. This is where I actually have 2 YouTube videos coming out. I'm so excited about on fascia. If you didn't know, I have a YouTube channel. Feel free to subscribe. I'd love to have you over there. And then you can use these with your patients, because one of the tips I give in pregnancy is actually to use a tennis ball, which I guess I thought I had, but I don't, and actually sit it on that area during pregnancy to help soften the area, right? Because we want them equal on both sides. Now, what happens is this goes for ligaments, this goes for technically fascia, but especially our pelvic floor, okay? That if we take and we have one side that's pretty tense, and then we have another side, okay, that's super stretchy, okay, that this one, where is baby gonna go? Yellow or blue? Yellow, right? So it's gonna go yellow side. And so if we're assessing or we're noticing baby's asynclitic, there's likely some restriction on one side. And so that's why I say when they're on all fours and you can have access to assess what's going on in there and then potentially release to create space, simple interventions can potentially make all the difference. So Hannah, I'm gonna have you back and we're gonna map out what's going on in her pelvis. I'll give you an angle there. You can get on all fours. Okay, and this is why we start with the anatomy. We've got to understand where things are inside the pelvis in order to know what's going on. I'm going to have you can go Kim too. Let me have you just scoot your feet towards me a little bit more. You can take the pillow with you if you want it, and just relax your body, all right? So I have the patient on all fours. Of course, I'm asking to touch them. Would it be all right if your partner did some butt massage? Oh, that's how you frame it, because it really is what you're doing, but you're doing it with lots of intention. Okay, and so I first have to know what's going on in here. Where are my landmarks? Especially if I'm going to assess a ligament and know what's going on. Specifically, we're talking about the sacrospinous ligament. Okay, oh my God. Specifically, we're talking about the sacrotuberous ligament. I misspoke, okay? Sacrotuberous, meaning ischial tuberosity. That's her sits bone. So I'm going to feel around. And I'm going to find that it's smushy in here, okay? That's like probably where her butthole is. And then I'm going to find those bony prominences. Her ischial tuberosity is right about here, okay? So I'm going to find the edge here. I'm going to find it over here, probably right about here, okay? So I got one of her sits bones. Then I'm going to feel over here, and you're not drawing on your patient's butts. But you have to know what you're feeling for in order to visualize where you're going, okay? So I'm going to say sits bones are right about here. I also know if we go above that the top of her pelvis is right about here. Right about here. It's not really showing up, but you get the idea. And then we know we got a sacrum somewhere in here, right? So I feel bone. It starts to curve in right about here, right? So I know there's a sacrum somewhere in here. Make sense? Right? Got to know what's going on. So I also know that the sacrotuberous ligaments connect sacrum to ischial tuberosities. Okay? So my ligaments are right here somewhere. Now, if I'm going to assess first, right? Assess is the first step of everything. And I'm here. They're on all fours. Labor has slowed. I am like what's going on here? You want to get on all fours. Would it be all right if I felt on your pelvis to see if there's any restriction that I can identify? They say, yes, of course. And then I'm going to feel landmarks, and then I'm going to take both sides, and I'm just going to follow towards, and actually hers, like they start up here. Big ischial tuberosities, girl. It's great. Okay. So then we're over here. All right. So I'm going to follow up to the sacrum. Now, if they have sensation, they're likely, if there's restriction, they're going to have some pain. Do you feel any discomfort?
No pain.
Okay. Which would have been my hypothesis based on what I'm feeling. So if I'm following along the way down to the ischial tuberosity sits bones, what I'm feeling for is spongy. They're both pretty spongy, and they feel equal amounts spongy. So normally there might be one that's really smushy and then one that's like pretty firm. Feels like a rubber band, thick rubber band. Okay, and if I feel that, I'm here. And I'm just pressing. And then I'm like, I don't have time because my patient's having a decel in the other room. So I'm going to grab you because you're monitored perfectly in category 1 or AA. And so I'm going to say, partner, doula, come here. Okay. And then I'm going to have them just place their hand on that place. Strong, steady pressure, not just pressure in that area. If you have a tennis ball, great for your comfort carts. I know they're not like wipeable. So like a lacrosse ball, even you could use something underneath a washcloth, heat first to help soften that restriction. You're here for 2 minutes, 2 to 5. Okay. Or they might love it. They can also rub on either side. Or if you're here, then I'm like, her ligaments feel great. So then I'm just going to have them do a little booty massage because any kind of massage will help activate, soften, create space, which we'll get to in a second when we talk about fascia. Okay. So we're assessing and we're feeling, hold on, get my remote, along the sits bones as a part of our assessment of the ligaments. Okay. And specifically this sacrotuberous ligament. All right? Makes sense? No? I got nothing. You're all just staring at me. We're good. Okay, thank you. All right, perfect. So that's the first one. You are free for a second. I will call you back with now your mapped out pelvis. All right? So that's for the ischial tuberosities. Now, what about the sacrospinous ligaments? All right, the sacrospinous ligaments are going to be internal. So how many of you have seen that you're pushing, kind of hands off, provider comes in, gloves up, they go in, and they are okay, hopefully not that aggressive, but it might be and they're clearly flexing their wrists with 2 fingers likely on either side. And what do we see sometimes? You've been pushing for hours. You're like, where have you been? Because you do that and all of a sudden, boom, baby comes. Right? What are they doing? What's the restriction? Likely the sacrospinous ligaments. Right? And you can feel them on vaginal exam with consent and ideally with an epidural because this might be sensitive. But when you're in there, as you feel around, you can feel when it's restricted, right? And you can feel on either side, there should be like a rubber band-like structure between the ischial spines up to the sacrum. And if it's super restricted, we've got to do some pelvic floor work. Because when you engage the pelvic floor, you're naturally going to also kind of pull on those ligaments. If that's restricted, is there more space for baby to come down? No. Okay? So you would feel that on vaginal exam. Will the provider, yes, thank you. Ellen, absolutely. Will the provider doing that increase tearing? Potentially, yeah. If they're, right? Yes, and we see it. Or they're doing that perineal massage and all of a sudden you see that bleeding, right? Instead, ideally, this is a gentle thing, and it can be done in a way that you're not tearing the perineum or the vagina, right? That instead, it's a gentle, steady pressure on specifically the ligaments, right? But this also sort of like with our perineal massages that we see, that's going to be more into the pelvic floor. But ideally, if you're going side to side, you may engage some of those ligaments. Ellen, I'm going to follow up with you one-on-one on that because I know that you're a doula and I love that you're answering that question because that is a hard one. It's hard for nurses too. The question was, what should we say? Some providers say that's massage. So I will follow up with you separately, but as nurses, what would you say if you were seeing a provider in there just, and do we say anything? Okay, I'll let you engage in the chat on that one, okay? So ideally, we're gentle, okay? We're pressing that there is some benefit to that, right? When done without cranking, all right? These are tender places we want to be very respectful of, okay?